Hello, everyone. It's a pleasure to be here with you today. And as Julia mentioned, I'm going to be talking about the digital transformation that's underway in healthcare at the moment and some things that we may need to think about. So where are we now? Well, if you look at the pandemic, and you heard from some of the other speakers today about the impact that the pandemic has had on transformation, particularly digital transformation. We went from 0 to 60 at the pace of a high-performance sports car in that time period. And so some things have improved, but as with most things, there are two sides to that coin. And so it also uncovered a lot of deep inequities that exist throughout the country and has impacted communities that are typically marginalized and underrepresented in the healthcare space. And so that propels us to do more. And what doing more means is looking at this from a lens of health equity and figuring out what we need to do as we think about the ongoing digital transformation and how we can take into consideration some of those aspects. So I'm going to start first with the positive aspects in terms of what we've been able to do thus far, and then we'll come back and look at some of the gaps that still exist. So when we look at telehealth, this is one area where I would say technology has leapfrogged during the pandemic, or maybe leapfrogged isn't the right word, but has significantly accelerated. Some of the data that we've seen is that in 2019, so right before the pandemic, in terms of outpatient visits for adults, it represented roughly 1% of outpatient visits. Other studies that have been done by CDC, you look at 2021 and 2022, outpatient visits from a telehealth perspective peaked at around 37%. As of August last year, that number had declined a little bit to 22%. In a separate study looking at mental health, use was at about 40% a couple of years ago. Now, I go out into the field with our teams about every other month, and we are in a variety of different therapeutic areas: gastroenterology, neuroscience, rare disease, and plasma-derived therapies. So from the gastroenterology side, for example, in my small sample set, most of the offices are now, I would say, roughly 2/3 to 3/4 back to in-person visits. And they expect it to stay that way. But yet on the mental health side, that number is very different. Other than the initiation of therapy with patients, most of the mental health providers that I've spoken to see 90 to 95% of their visits virtually, and they don't expect that to change. So a wide range in terms of telehealth usage going forward, and I'm not quite sure where the dust is going to settle on this. Another area where we've seen some significant advances is in terms of clinical trials. So you may have heard the term decentralized clinical trial. What this means is that we are able, in terms of leveraging technology, to separate what needs to happen in terms of clinical trial activities from a physical location. What does this do? Well, when you look at it from the lens of health equity, it has allowed greater access. Because a lot of times, more diverse populations, they frequently tend to be in roles that may or may not have good awareness or access to clinical trials. When you look at rural populations or populations from socio-demographic areas that are more challenged, they may not have the transportation options. Where they live might be far away from the clinical trial site. So by separating from the physical location and leveraging technology, we've created more access for diverse populations to participate. So this is something that from a Takeda standpoint, for example, we've launched 11 fully decentralized clinical trials since 2021 and have roughly 76 trials that use some level of digital technology in the clinical trial. So I think this, for our industry, is akin to moving from, well, actually, as I'm looking across the audience, this may not resonate with you. You'll have to ask your parents or maybe even your grandparents. We used to have to go to the AAA office, right, if we wanted to plan a vacation. You physically went, sat down with someone, went through what you wanted to do on your vacations, looked at hotels and made those reservations, etc. Well, now everyone uses TripAdvisor or some other similar platform to do all of that planning. You're not tied to a physical location. You're not tied to doing things directly. It can all be facilitated by technology. Now, a third area is in terms of data. So what all of this technology has provided us with is a lot more data. And when you're in rare diseases, for example, the wealth of data can be fantastic because it can help us now, for example, accelerate the time to diagnosis. And even in the US, for most rare diseases, it can take 7 to 12 years for an individual to be diagnosed. But data can help us shorten that. Now, we're not in Amazon, we're not in consumer product goods. So in healthcare, we do have to make sure that we are treating data in a responsible manner. To stick with the road analogies, we can't stand still and create traffic jams, but we also can't drive recklessly and injure people along the way. So we have to make sure that we're looking at data responsibly, but today we have a wealth of data to work with. So, as I said, these are some of the things that have gotten us to where we are today in regards to digital transformation. But when we look at it through that health equity lens, there are still some gaps that we have to address so that we make sure we're not continuing to leave communities behind, or worse, misdirected. So in classic GPS style, let's recalculate and take a look again at those same areas, but from the lens of health equity. So when we talk about telehealth again, here you can see some numbers, and this was a study done by Ernst & Young in, I think it was 2021. 23% of US households lack a desktop. And when you look at Black and Hispanic households, that number jumps to 30%. And then when you look at low-income areas across the US, 17% of those households are more likely to have a smartphone than a laptop. All of these things have implications for how we continue to use technology to transform how we deliver care for individuals. And so if we don't close some of these gaps, then we're going to continue to leave populations behind. And so while this doesn't necessarily speak to direct healthcare delivery, it does speak to some of those social determinants of health that you've probably heard about when you talk about health equity. And then the final data point here, this was a separate study, I believe this one was done by the University of Chicago, when they looked at the adults who have used telehealth. There were equal percentages in terms of white and non-white populations. But the non-white populations reported, 63% of them reported that they were concerned about the quality of care that they were receiving when using telehealth. So again, some disparities that we need to address. And when we talk about the trials again, the decentralized clinical trials, at some point I do believe that all of the clinical trials will move in this direction because it helps with a lot of things that we talked about earlier in terms of better access, more readily available data to analyze that will speed up the process overall. But as you saw from the previous page, not everyone has laptops or smartphones or access to technology, and some people, quite honestly, may choose not to. So from simple things like e-consent forms that in general make things easier for everyone involved, it doesn't work for everyone yet. So it's a little speed bump in the road that we have to get over, and eventually we'll be able to make it through all of this, but we have to make sure that as we continue to adapt the use of technology in things like clinical trials, that we do so at the speed of human adaptation, not just the speed of technological advances. A more complicated one that has put lots of potholes in the road are things like the data platforms that are used to support clinical trials, because today they don't all speak to each other. So it can get very complicated for a particular clinical trial site or for a patient who's trying to manage through these tools. So it's like, when we used to have 5 different remotes to operate the TV just to watch one show, and you had to figure out which remote to use. Well, today it's much simpler. We've got a universal remote. We don't have a universal remote yet in terms of clinical trials, but we'll get there. And then finally, as we all know, when it comes to data, and particularly in this age where we're talking a lot about generative AI and being able to train AI through and machine learning processes on data, we have to be careful about the biases that can exist, especially in the healthcare field, where the bulk of clinical trial data, the bulk of that has been studied on Caucasian men. So when you look at, and these are some of the boxes that fit me, these don't all fit with the data sets that exist in regards to health and health data. So we have to make sure that the data that we are using to generate new insights, whether it's through using AI or other methods, isn't rooted in bias. And I'll give you a quick non-healthcare example to illustrate this point. So I don't know how many of you are familiar with what's called the Kodak Shirley card. So this is an employee that was a Kodak employee whose picture was used to calibrate color printers. Right, so Kodak was, out there as a leader in terms of color printing, and they needed to have a way of calibrating color printers so that high quality could be reached regardless of where you are. Well, this Shirley happened to be a very pale, dark-haired woman, and her picture was used up until just a couple of years ago to calibrate all color printers in the world. Right, so any of you who don't have really pale skin, sometimes you see that in photos, your skin color doesn't look that great. Why? Because it was calibrated on the image of Shirley up until a couple of years ago when Google created real tone color calibration. So there was no bad intent there, but there's bias in that calibration. And so that's the type of thing that we have to keep an eye out for as we look at the data sets that we are using to further advance the digital transformation in healthcare. Oops, sorry, forgot about the animation. So a lot of different complexities that we have to take into consideration when we look at how we need to design for equity as we go through digital transformation in healthcare. So now I want to share with you some thoughts to take into consideration as you do this. So first, the fastest route may not be the best one. Now, all of us have lots of experience that we use, and we make assumptions sometimes when we face a new situation or come to a complex problem so that we can help speed the process to come to a solution. Well, sometimes by making those assumptions, there are biases that are inherent in that. It might be recency bias, it might be recall bias or confirmation bias. These sorts of biases are things that we need to be aware of so that as we are looking at a situation and wanting to come to a conclusion at pace, that we pause, because the fastest route in terms of using those assumptions or experiences may not give us the best solution, particularly when you're trying to address health equity, because most of the time the experience set that exists out there doesn't necessarily reflect those of the communities that we are trying to reach. And so making those assumptions can lead you to a wrong conclusion. So what do you need to do instead? Well, we need to pause. We need to meet people where they are, and we need to understand what their perspectives are on the situation. And let me share with you a quick story here, because it may not always be technology, or sometimes it may be technology, but if it's not deployed in the right way, it won't be useful. So recently I met with a pastor who's from a rural part of Southwest Georgia. And he was sharing with me how he and his community addressed prostate cancer. So this is a big issue in his community, and others had come in and tried to make headway here, but they didn't get anywhere. So he and a few of his friends got together and said, how can we help? So they leveraged community elders and they leveraged the barbershops. They held events like Haircuts and Ham, where at a church rec center, they would bring in the local barbers. You can get a free haircut, you get a free ham dinner, and you get your PSA screening at the same time. Okay? Doing this helped to create a safe space where the conversation could be had about prostate cancer, about detection through PSA testing, and the connection to the local community hospitals to get care if needed. And they were quite successful in doing this. Why? Because they looked at it from the lens of their community. Who would make the most impact? How would they make the connections with the other individuals? So I share that as an example of, really understanding and listening from the community perspective what is needed. You might come to a different answer and a better answer to address the situation. And finally, approach with curiosity. So I mentioned this a little bit already. There's so much technology that is impacting our landscape in terms of healthcare. And we're not the fastest, okay? There are other industries out there that are doing much more with technology than in healthcare, but there's a reason for that. What we do impacts the lives of people. Sometimes it's life or death. And so we need to approach with curiosity, meaning ask questions. Don't stand still, as I mentioned before, and create traffic jams, but don't go ahead recklessly because you might cause unintended harm. So spend some time, ask the questions, understand what it is that we're trying to accomplish, create principles to help guide you so that you can experiment and learn as you go, but do so under a set of principles that you are following. So we've covered quite a lot of ground in the last few minutes and talked about a variety of different aspects that are really complex in terms of trying to address the deep inequities that exist in our country today. But the digital transformation that is happening will continue to go on. So I want to leave you with 3 thoughts. First is to listen with empathy. Hopefully some of the examples that I gave you illustrated this point for you as to why we need to start with listening. But if we do that, then we can proceed at the speed of trust, because listening with empathy will help to create that trust, and then we can move everyone along together. The second is to experiment with care. As I said, there's so much going on. We don't have all of the answers today, but we can't stand still. So the experimentation is an important aspect. And it's great that we have no right answer, and we can all work at different angles on this, but we have to do it with the understanding and the responsibility that there are patients on the other end that can be impacted by what we do, and to keep that in mind. And the final thing is to collaborate and co-create. The challenges that are in front of us with health inequities are too huge for a single organization to address. And so we need to work together, sometimes in partnership that aren't the norm. Sometimes it's with other who we might normally view as competition. Sometimes it might be across public-private lines, or all of the above. By working together and co-creating, listening to the people that we are trying to address, is the way that we can move forward in a way that will bring everyone along with us. Because in the end, that is our goal as we continue down this journey of digital transformation, that we do so in a way that brings everyone along with us so that we can do the most good for most people together. Thank you.